Welcome to another episode of Cutting Edge Health. Today, we're talking about SI joint arthritis, a new way to diagnose an old painful problem. If we haven't met, I'm Dr. Orlando Landrum. I'm a physician who helps patients understand both physical as well as mental pain and how to be able to punch pain in the face and get back to leading the life you deserve. Today, we're talking about a physical type of pain that's dealing with the SI joint. We're going to explain that in depth and detail so that even if you're not of the medical profession, you can understand exactly what that means. Many people have not heard of the SI joint. It's less common than hearing things like a herniated disc or sciatica, or even things like arthritis of the back, like facet arthropathy, or even stenosis. But SI joint pathology or arthritis is probably one of the most commonly missed areas of back pain, and we want to be able to make sure that you, as a patient or person who's concerned about someone who has a problem like that, are aware of exactly how it shows up and how to be able to identify it with both old school diagnostic techniques as well as the newer school techniques so you can get the best outcome possible. So when we talk about back pain, it can be very diffuse, meaning it can be spread all the way throughout different parts of the back, from anywhere in the middle of the back to the low back to the sacrum. And normally when we look at an imaging of the low back, it looks a little something like this. So if we're taking a look at a spine and we're to bring this in kind of into focus, you can see areas that sort of sit like this, where you have portions that are the vertebral bodies, you can see the nerve roots, and you can see them then come up until this area that is and around what most people would think are the hips. But this is actually the sacrum and components of the ilium. And we're going to explain that in depth and detail by teaching you the anatomy and teaching you why you hurt. So when you look at that from an x-ray standpoint, it looks like this. So you have a whole host of different pictures all over the places, and you have stuff that's just like, how do we make this out? And we're going to explain that so that you understand it, that you get it, and that it's going to be something that you're going to be like, yep, this is how it should be done. So we're going to make sure you get it, right? So let's break down these different bones and kind of explain it a little bit better. So you can look at this area of the sacrum and pelvis form a circle. And these bones interconnect. And if you look at the areas of both the white on the one side and kind of the green or teal areas on the other side, you can see that they are interconnected. They're not one bone. They have two joints that sit in those areas. And then if you look in the lower portion of this, there's a black area labeled number 5. That's another connecting area. So there's 3 points of joints that are present. When we've spoken about regenerative medicine before, we talked about how to be able to optimize that function so it has normalcy, which is traditionally stability with not that much movement that's present. When we have movement that's present, that's significant in nature, which is typically greater than 2 to 3%, we typically have pain and arthritis associated with it. Let's take a look at another cartoon picture that kind of looks at this and explains why there may be some degree of confusion and with traditional back pain. As you can see, there's this huge yellow structure that kind of runs underneath that area, and that is the sciatic nerve, comprised of a number of nerves that come from the back. So if we were to kind of take a look at this in the areas of the 3D model, what we would see is we see this area that's like this, and we see the sciatic notch that comes in and kind of forms this area where these nerves would kind of form here and then go down. And so when most people think about a sciatic pain and an SI joint pain, they think that that pain is localized to the back only. And that's not actually the case. Many times that pain spreads down into the leg. And it's one of the reasons why most commonly this is a misdiagnosis treated for the back, and surgery is sometimes performed when surgery should not be done, where it's thought to be in the low back in the lumbar region. And then after the fact, after there's been a discectomy or a fusion that's in place, it's like, oh, we kind of made a mistake. It should have been the SI that we treated all along. It's kind of a big deal. So let's talk about how frequently does this occur. In one of the papers, they say that SI joint and low back pain is present in about 1/4 of people that are walking the planet. And about that same amount, 74 million or so, give or take, in the U.S. have low back pain in the last 3 months. And about 10% of the U.S. population, so 1 out of every 10, has some degree of chronic back pain that stays with them indefinitely. So what are some of the red flags and issues to be concerned about when you or someone you care about has back pain? What are the following? Has this person had a history of cancer? Are they immunosuppressed? Do they have infection? Have they had a trauma? Have they had any changes in their neurologic condition that affects their ability to be able to control their bowel or bladder? Do they have issues with progressive weakness in lower extremities? All these things can be important. And traditionally, what we would say is, well, if we're going to figure this out, let's get some imaging. It'll be able to kind of tell us what the problem is. Well, imaging has its limitations. So there's certain things imaging cannot show us. So if you try to get imaging for pain that goes down the leg, sometimes it'll show you things, but not always. If you have an issue with stenosis or narrowing, sometimes you can see it with imaging, but not always. If you have a cauda-equina infection malignancy, there's certain types of imaging that can show this to you. But the problem is SI joint doesn't always show you what you need to know from imaging alone. So that results in you having to do different type of physical examination tests that you can either be able to replicate, or you can be able to have a question to your healthcare provider about the tests that they're utilizing. So there's a paper, as you guys know, we really rely upon the science to be able to help guide what makes sense. There's a paper that looks at SI joint problems. They talk about how to be able to identify it on the x-ray. You can see this joint that's present, which looks like it doesn't necessarily have a problem. Or if we were to angle it a little bit and look at an oblique view, we can see even that joint even more prevalent, where you can see that black arrow that's present. But the question is how do we diagnose it? And historically, the way to diagnose this is by using 5 different provocative tests. So provocative tests, meaning ways to be able to cause different elements of pain during the examination to an extent, not trying to hurt the person, but to an extent to see if you can replicate the type of pain that's normally present, to then be able to say this pain is indicative or suggestive of it being an SI joint problem. So we're going to show you some pictures that come from this paper that replicate what the traditional standard of care is in most practices right now. And so one is by pressing on the aspect of the iliac, those bones that are in place, by doing an anterior pressure. The second is by bending the leg up and having a bit of a twist. That's called the thigh thrust test, and the pressure that's applied. The third is something that's called Gaislian's test, where you have a rotation with pressure on the opposite leg as it hangs down. The fourth is pressure directly on the hip bones. And the fifth is by pressing with the person turned stomach facing down. And what they've actually been able to see is that normally, if you can get 3 out of the 5 tests, then it's been suggestive that you actually have some degree of SI joint problems. However, there has been new data that has looked at, is there a better way than just the 3 out of 5? So that way you're not missing it, or you're not doing an early diagnosis, which can be unclear. So the summation of that is, for the most part, 3 out of 5 of those provocative tests, meaning those tests that attempt to try to replicate it, can be indicative of pain. But there's a paper that just recently came out in this year that talks about a different type of way to differentiate or tell the difference. So in essence, what we're saying to you is a better way, a different kind of way that might be useful for your clinician. And so in essence, you're going to say it with your chest to say, hey, this is maybe another alternative that can give us more information than just those tests alone. And so what that paper did is it referenced the element of how frequently surgeries occur, which is about 13%, that sometimes didn't need to have a surgery done in order to be able to assess it. And so SI joint pathology is present in about 15 to 25% of low back pain, right? So if that's the case, then we need to be finding that. And one of the ways to be able to kind of get after that is the 5 provocative tests that we talked about. But what if there's another way that gives us better sensitivity? And so There's one study that looked at about 166 patients, and what they did is that they used different tests than the traditional 5 that I just showed you. And those tests are 3 different tests of the following. So one is where you have the patient sitting and you have pressure that's applied, as you can see where the thumbs are and the red line in relationship. And then the second is to have the patient lying on their back, as you can see this person's belly button, and there's pressure that's put on the anterior forward portion. And then the third is an area that's placed and pressure applied to the bottom surface of the feet or plantar surface, which really is like, oh, wow, this is a little bit different and unique. But because of how the nerve influences components of the areas of the bottom of the foot, they found that these type of tests were able to give a better sensitivity than what they would have by just doing the 5 provocative tests. But by adding these others, you can get a better outcome, better understanding, and better evaluation. Something that is new, hot off the press of saying, let us be able to identify back pain and differentiate it from stenosis. Make sure it's not fasciitis arthropathy or arthritis in the back. Make sure it's not sciatica or pain that's radiating down the legs, by being able to determine that it is indeed due to that joint that sits in the area that's associated with this region that's present right in here, right? And be able to determine that that pain is pain that's present not only in the back and the glute, but potentially going down the leg. This hopefully will be able to help people be able to understand not only that this is a pain, but what it's caused by, so you can treat it even better. Hopefully this gave you some value. If so, please hit the like button. If you're interested in learning more about how to be able to take control of your life, how to be able to take and punch pain in the face, whether it's physical or mental, please subscribe to the channel. Thank you so much for your time, and have a great day.